Okay.
All right, so I'm going to be going over the nursing ortho competency skills checklist that everyone will need to do and be competent at. I'm going to be going over a few different things here. The first thing being communication. So the first thing I want to talk about is the difference between PT and OT. So some people might not know the difference. There are a lot of similarities, but there are some key differences. At least in the hospital setting, physical therapy focuses more on leg strength, walking, and balance, as well as transfers, so getting out of bed, out of a chair. Occupational therapy also focuses on the transfers, but they don't really focus on the walking part. Their specialty is something called activities of daily living. So things like combing your hair, brushing your teeth, putting clothes on. They give patients tips and tricks on how to do that, or if they need any adaptive equipment, they'll also educate them on what they may need, depending on the precautions for the joint replacement. So that's the main difference. So part C here, being knowledgeable about the process of communicating the patient's mobility status with therapy. So as we all know, we've been using the mobility scorecards as well as the whiteboards. So after each session, the therapist is supposed to be updating the whiteboard as well as the mobility scorecard. Not only that, but we try to make a conscious effort to verbally communicate with the nurse regarding how the patient did. So there's two forms of communication there. It's written and verbal. Being knowledgeable about hip precautions. So there's two main approaches to replace a hip. There's an anterior and a posterior approach. I'll talk about the hip precautions first, and then I want to briefly touch on the hip nailings, or the ORIFs, and then as well as back surgeries. So as far as hip precautions go, there's a posterior approach and an anterior approach. So the posterior approach consists of not bending less than 90 degrees. So functionally what that means is you don't want to bend down like this in the standing position, or if you're sitting down, you don't want to bend down like this either, okay? You don't want to cross your legs with the posterior approach, so no crossing legs in standing, sitting, or supine. And then finally, for the posterior approach, you don't want to turn the surgical leg inward. So what that is an internal rotation of the leg, and you don't want to turn it inward. These precautions are mostly in place to prevent dislocation. So that's the posterior approach. The anterior hip precautions is you don't want to extend the surgical hip past neutral. So what that means functionally is you don't want to, let's say the right hip is the surgical hip. You don't want to step back first with the right hip. You always want to step back with the non-surgical. What that also means is you don't want to have the patient bridge to get out of bed for an anterior approach. So what bridging is basically if they're on their back, if you bend their knees and they lift their bottom up off the bed, that's considered bridging. And you want to try to avoid that with an anterior approach.
Brent, can you tell us which physicians use which approach?
Yes. So from my experience, Dr. Mellis and Dr. Guth do the posterior approach, and then Dr. Fritz typically does the anterior approach. Another thing I want to add as well, for a posterior approach, you don't want to get too low of a chair. So we have specific hip chairs on this floor, and they sit a little bit higher than the recliner chairs and the other green chairs. Ideally, you really want to try to find that type of chair to sit a posterior approach patient in, because you don't want to break that 90-degree plane that I was mentioning. For the anterior hip, you're allowed to bend. The only thing you don't want to do is extend, like I said. So as far as sitting in a lower chair, they're able to do that. There's no restrictions regarding that. So those are the two main approaches. For the most part, you'll see posterior approach. That's the most common, but Dr. Fritz does do anterior approach. In regards to the hip ORIFs, which is an internal fixation, usually they do that. Usually the population for that is elderly and they've had a fall. So with that, there isn't any movement precautions with a hip nailing. Where you see the precautions with the nailings is weight bearing status. So I'll cover that in a future video, but just so you know, there's no movement precautions for a hip nailing. In regards to the back, so the back precautions after any back surgery, it doesn't matter what it is, if he's just repairing the disc or if he's doing a whole fusion, You don't want to bend, lift, or twist. So BLT, that's how we have patients remember it. So you don't want to bend down like this, and again, in sitting or standing. You don't want to lift any more than 10 pounds. So a gallon of milk is around 10 pounds. And then you don't want to twist like this. So where that really applies is getting in and out of bed. And I will show you how to do that in a future video as well. But you want to do what's called the log roll technique. And then, yeah, that pretty much covers the first section.